At the Emergency Operations Center in Pantan, scores of disease control officers keenly monitor screens displaying data on infectious diseases recorded across the various regions. With surveillance systems and protocols in place, Director General of the Ghana Health Service, Dr. Samuel Kaba, believes the country is well positioned to deal with emerging infectious diseases.
From today, we need to tighten our belts towards that. As I said, you guys have to read more about the disease so that you don't miss.
But preparedness is not just a statement. In many community and district hospitals, when an infectious disease breaks out, there is nowhere designated to manage the case.
The current practice is that when somebody comes with such a disease, let's say, for instance, tuberculosis, we have a very small room that we put the patient in. And there are times where you have to put another infectious disease patient in the same room, putting that other patient at risk of acquiring the tuberculosis.
But in the districts where these infectious disease centers are needed, contractors have abandoned work, while in other areas where the projects have been completed, the medical equipment required to make them functional has yet to be installed.
The original plan was a 30-bed capacity hospital that was supposed to be fully functional. What I mean by fully functional is that it has everything that it requires: a laboratory unit, X-ray unit, it has beds, admitting facilities, anything. And it was supposed to be ready anytime there's an infectious disease outbreak that we needed to do mass admissions and critical care. Unfortunately, the project started really well, but over the years, the contractors have left the site.
Imagine treating tuberculosis, COVID-19, and Mpox patients in the same ward. Different infections, same air, same risk. That's the reality at the Nalarugu's Baptist Medical Center in the Northeast region. When the first suspected Mpox case arrived in Nalarugu last year, there was no specialized infectious disease center waiting. According to the medical director at Baptist Medical Center, Dr. Isabella Amisi, the facility had to rely on makeshift single yard.
We had to create makeshift rooms to house these people, because if you put them in the general population, you are just going to spread the disease to all the patients on the ward you put them in. So an infectious disease center is usually a specialized unit that can contain the diseases, filter the air in the rooms, and allow the patients to heal and recover without posing a great risk to others. So this is very significant because you are limiting the spread, limiting it through the mode of spread, especially usually the airborne diseases. And then there are also special precautions in these wards to help limit other forms of spread, like contact, spread, and all that. So an infectious disease center is one of the ways in which we can prevent public health crisis. So it's very important in any setting. And given that Baptist Medical Center is a big hospital, the risk is more evident if you put even one person in a ward that takes care of 40 patients at a time. So it's very important to have the center built and as quickly as possible, because we don't know when the next pandemic or epidemic will happen. Recently, we had monkeypox. We had to find a place to put them. We could have kept them in such a ward.
This single room was once meant for tuberculosis alone, but over time, when infectious disease patterns changed, the space did not. Dr. Amisi again.
So when the hospital was established, TB was very predominant. So there was a small isolation unit that was built. It houses just about 4 on the TB side at a time, 4 to 8 patients at a time. So that is where we normally put our patients, but it's not differentiated into more units. They are not individualized rooms. So that means if whatever infectious disease comes, are you going to put them all in the same room? So risking all their lives to exposure of, you came with one disease, maybe I came with meningitis, and then I'm lying close to somebody with TB without the systems that filters the air. I may get the person's TB, but I can also be kept in the general ward because I pose a risk to other patients on the general ward. So that we are still managing with that small isolation center, but we have outgrown the center.
In this documentary, Kwetenate explores why some infectious disease centers have been abandoned, the national framework for citing these facilities, and the standard protocol for managing infectious diseases within a single yard. I have come to meet Dr. Franklin Esiedi-Bequin, a public health physician with long-standing experience in disease surveillance, outbreak preparedness, and response. He believes that managing infectious diseases does not depend solely on the space where a patient is treated. According to him, the standard protocol rests on whether the cases can be properly managed there or require isolation.
No, so first and foremost, you need to be able to ascertain the kind of condition you are managing, and then also whether you have the required human resource to manage it. So, let's say if you have a disease condition, first you need to confirm it and make a determination. After that, you also need to ask yourself, do you have the human resource to manage that case? Then 2, do you have the required setup in terms of equipment, in terms of management of the case itself. So let's say if you have such a case in a location and you do not have that, the next point of call is that you need to find a way of referral. And clearly now we have our transport by way of ambulances are quite improved in terms of numbers, so we need to refer. So for highly infectious disease conditions, that's where you need to manage them in infectious disease centers, and the prominent one is the one at GIDC. So if you have such a situation, first and foremost, you isolate and make a determination whether the case can be managed there or you to refer. So basically that's the principle in managing infectious disease conditions.
I know this does not fall under your domain, but in an instance whereby, let's say, a facility at a community level has 3 different infectious diseases, let's say tuberculosis, cholera, and let's say mpox, and they only have 1 ward for managing infectious disease, how should it go, or what should be the standard protocol in this picture?
No, the principle does not change. It's about isolating them. You see, there are some instances that we put up tents. The idea is that you don't want the infectious patient to contaminate others. So first you isolate, and then, as I say, make a determination what to do. Are you going to refer, or you try and make a makeshift site to manage the case? So that should be the principle. You don't want to mix that pathogen with the general ward. So that should be the principle. And then you decide that I will manage. Let's say if you have Ebola.
At the Eastern Regional Hospital, the holding bay for infectious diseases is an improvised space created during the COVID-19 period. The hospital's management collapsed several units to create the facility, which has an 11-bed capacity. The medical doctor, Akoto Ampao, says it was designed to meet changing trends in disease management.
These emerging diseases, when we have severe cases, be it from the district or we find them out de novo in our facility, we would hold them in the infectious disease center, which we call the medical annex. That is the name we have given to that one. Post-COVID, management has maintained that ward for that purpose. And a few times where we need to seclude patients because of some known diseases which we think may be infectious. For example, a pulmonary tuberculosis where patient is actively coughing, we do transfer to hold them in that area. But there again, this area has reduced the bed capacity for the hospital because it's not actively used for the purpose for which it was intended. I mean, this is a carved out area, but because we understand that these emerging diseases are now becoming rampant and facilities lower than the regional hospital in the district would depend on our expertise for management. We have decided to dedicate those wards for the management of such cases.
For disease control officers managing different infectious diseases in this makeshift structure, it has become a dilemma. Esther Avoka is the disease control officer.
It's very challenging having just a ward that is serving as a makeshift for infectious diseases. We have various forms of infectious diseases. You cannot mix TB cases with people who are coming in and are being diagnosed with mpox, or cases that may come in whether dengue fever and other infectious diseases. The transmission differs. Okay. So we need to have a space, and even the place is not conducive enough. If you see the airflow of this area, it's not so conducive, and where it is located. So it is challenging. Moving cases, some out and some in, it defeats the purpose of infection prevention.
So if you have, let's say, 3 different infectious diseases, then what happens?
It means you have to prioritize. All right. You look at the one that is more infectious. So if you are looking at Ebola and you are looking at TB, you prefer to move TB to the ward, which is an airborne condition, and then maybe with nose marks. It is not droplets. It is airborne. It's droplet nuclei. So the infection of TB is less dangerous than if it is a case of Ebola.
The risk of cross-infection to patients and health workers increases significantly. Mrs. Avoka again.
It does, but once you don't have the resources, you have to manage with the little that you have. So currently we are constrained with space, and that's the best that we can do.
This became evident when the region recorded its early cases of mpox. Jennifer Ano Entry is disease control and surveillance officer in the Eastern region. She shares insights on how it was managed.
The person didn't have any history of traveling or any history of, let's say, traveling elsewhere, or he has not traveled even 1 month prior to the onset of the symptoms. So we actually couldn't point out to where the infection was contacted, or we couldn't have traced it. But because he didn't have any travel history, he didn't have history of coming into contact with anyone with similar signs or symptoms.
Can you describe the condition in which your team found this patient?
Okay, so on arrival, we realized the patient was having there was fever, and there were also rashes which were vesicular in nature. When I say vesicular, it means rashes which were in the form of bumps with fluid-filled rash. Yes. And with all over the skin, from the face down to it was scattered all over the body.
Last September, according to dashboard on the command center set up by the Ghana Health Service to monitor infectious diseases, there were 547 epidemic-prone diseases from all 261 districts. Influenza-like illness and severe acute respiratory infections were the most reported cases, closely followed by Mpox and COVID-19. As of the 18th of January 2026, the country had recorded 12 new cases, bringing the total confirmed cases of Mpox to 980.
Since the outbreak began in May 2025, the Ministry of Health, through the Ghana Health Service and with partner support, has activated a coordinated multi-sectorial response aimed at interrupting transmission and protecting public health. For clarity, while 880 cases had been confirmed as at 25th November 2025, the situation update as at 3rd March 2026 is that Ghana has recorded 1,038 confirmed cases and 8 deaths, largely among persons with underlying health conditions. 124 districts across all regions, representing 47.51%, have reported confirmed cases.
But while Nalarigu is yet to record its first case of Mpox, a 15 million Ghana cedis infectious disease treatment center, conceived at the height of COVID-19, has been abandoned. In 2020, the government awarded Macrostructures Limited the contract, 4.5 million cedis. 30% of the total sum was paid upfront. 6 years later, only 10% of the work has been done. When Joy News visited, the project was still at the foundation level, with no contractor present. The site had been overtaken by overgrown weeds and stagnant water. Dr. Isabella believes such an infectious disease center would have become a game changer in healthcare delivery, as the current facility has outlived its usefulness.
We more or less represent the region when it comes to all of these infectious diseases. So most people come to us for their care, and we can't keep putting them at risk like that. It's very appropriate to find better ways to manage our infectious disease patients. This is not ideal, if I would say.
Assembly member for Zari Fon electoral area, Bukari Husseini, said they became anxious given the resurgence of other infectious diseases in parts of the country.
People of this community, we are afraid that if in case we have something like that in our jurisdiction, where are we going to send the person to? So we expect that the government should look for the contractor who the contract was awarded to come back to site to continue, so that as and when something of that nature occurs, we can have a place to refer the person to.
Director of Public Health at Ghana Health Service, Dr. Franklin Esiedu-Bakwin, explained the national policy on siting of infectious disease centers across the country.
Basically, you need to look at this is the risk of having a condition in a location, and also look at available resources that exist. So for Ghana, we have, I would say, 3 epidemiological zones. You have the northern zones, the middle, and the coastal. So northern is more of the Sahel or the Savannah, and it has its unique kind of disease conditions, like meningitis. That is more unique at the northern part of the country because of its characteristic climate. They have the forest. You understand? They see the Ashantis, part of the Eastings, and part of the Bono regions. Those are the forested regions. They have the coastal, which is where we have the seashore, which is common with small cholera. So in making a determination, you need to see what disease patterns are you likely to have.
The Auditor General, in a special report on COVID-19 expenditure between March 2020 and 2022, stated that several efforts by the Ministry of Health to get the contractor to return to the site have proved fruitless. The report recommended that the Chief Director of the Ministry of Health recover the mobilization amount, terminate the contract, and re-award it. Failure to do so would require the Director to refund the amount. Efforts to get the Ministry of Health to comment on the matter have proved futile. However, in an RTI request filed by Joy News, the Auditor General indicated that it has not surcharged the Chief Director. When the news team spoke with the contractor, Yao Dankwa, he blamed delays in payment for their inability to complete the project. He revealed the project has been terminated. Nalarigu is not alone. A 30-bed infectious disease center that was conceived during COVID as part of a national response in the Western region has been abandoned. A public health doctor at the Fiankwanta Hospital, Maxwell Appiah, said his team currently operates a 16-bed facility. When it becomes necessary, they resort to erecting tents outside to contain the situation.
And if we are able to complete it, it's going to help us immediately. It's going to increase our capacity to be able to admit more. Currently, our bed size is 16, and on a normal day, we have infectious disease patients, mainly tuberculosis patients, who are on admission in our facilities. And so, if we get an outbreak that needs more patients, often would have to create spaces out of other places. But when we get a 30-bed hospital, it's certainly going to help us to be able to manage them more effectively.
But infrastructure is only one problem. The facility that used to boast of several health practitioners now has one permanent doctor and 5 nurses. Dr. Maxwell Appiah again.
For some time now, the ministry has not been recruiting as many doctors, nurses, and other health professionals as we wanted. And unfortunately, especially during 2023, 2024, a number of healthcare workers left Ghana. Many nurses, doctors, and others left for greener pastures outside. And as always, some will retire and all that. But unfortunately, the service has not been able to recruit enough people to replace those that we lost through these situations. And therefore, there's a huge human resource gap. We currently do not have as many nurses as we require. We do not have as many doctors as we require. And then our lab, for some time now, the lab units, they are not even recruiting lab staff. And all these things has led to significant shortages in human resource. And therefore, we are not able to attend to the patients the way we would have wanted to. That's a big challenge.
So let's look at how many you've lost and how many are currently serving at the infectious disease center.
Currently, I'm the only permanent doctor here. That's the first thing. And then for my nurses, I remember 2023, 2024 was a very bad year for us. Bad year in the sense that starting from October 2023, every month a nurse left to go outside. So from October, the first one went to Canada. November, the next one went to Canada. December, the next one went to the US. January, the next one, just like that.
The stalled 30-bed infectious disease center is already having telling effects on healthcare in the Western region. In a study conducted by researchers, Vetanen and others on patients with infectious diseases, overcrowding and health in hospital staff in Finnish, they found out that overcrowded wards contributed to high prevalence of infectious disease among patients. This tend to have adverse effects on the health of hospital workers. For patients, it means delays in accessing services for their family. Alhaji Al-Hassan, a relative of one of the patients receiving care at the facility, said they spent long hours waiting for lab results before doctors proceed with treatment.
I think we send it there for renewable, and then at the same time they give us some numbers and then lab tests to go and do the tests.
How long did it take for you to do the labs?
Oh, actually it took about, when they refer you to a field contact, there's a pressure over there. It will take you about 2-3 hours.
In Goso, in the Ahafo region, the infectious disease center stands almost finished. But almost is not enough during an outbreak. When journeys visited the holding center there, it wasn't functional. Sensor control panels have not been installed. Hospital authorities say the Team X-ray machine deep freezer, and stove are yet to be supplied. In Zebula, in the Upper East region, the center is completed, but without ventilators or X-ray machines. Medical superintendent at the Zebula Government Hospital, Ayubi Abdul Rahman, said infectious diseases facility has been repurposed to take care of more pressing needs of the hospital.
Since taking over, we've put it to use. Most of the time it was handed over, of course, we were not having any issues of any an infectious disease outbreak, and so the facility obviously cannot be left unused, and so we've put it to good use. We have the neonatal intensive care unit that is occupying part of the facility. We also have the pediatric unit also using some sections of the facility, and of course we've reserved some areas in the event that we have cases that we need to isolate. And so that's the current situation.
In December 2025, Ethiopia recorded its first ever outbreak of Marburg virus. Though the country has declared an end to the epidemic, the signal that emerging infectious diseases has no boundaries is clear. As Ghana struggles with unfinished centers, however, Director General of Ghana Health Service, Dr. Samuel Kaba Akoreya, insists the country is ready.
It took one case of Ebola, and the entire West Africa was shut down. Many people were COVID. Many people were affected. The entire world went into crisis. And so, don't say it's only one case that you might be detecting. It matters a lot. That one case is what is going to shut us down. That one case is what is going to kill you.
The country has emergency operation centers set up at Pantan and Kolebu teaching hospitals. A case management team stands by and is activated when necessary to ensure the country does not engage in firefighting in the event of an outbreak. Irrespective of how the picture unfolds, Ghana sits at crossroads of emerging infectious diseases, with bricks, equipment undelivered, and critical infectious disease centers abandoned. The nation's resolve could be tested again, because when the next outbreak comes, the question will not be whether Ghana was warned, but whether leadership acted decisively. For Joy News, this has been Kwete Nate.